Welcome back to the deep dive. Today we are wrestling with one of the most professionally stressful topics in medicine, how to draw a hard line with a patient. We're diving into the exact rules that govern when you can, or, and this is key, when you must end a professional relationship.
And this isn't just theory, is it? This is the bedrock of compliance.
Yeah.
We're looking directly at the current GMC guidelines, updated through early 2024.
The very same ones that form the basis for professionalism assessments.
Exactly. Particularly the MSRA situational judgment tests, the SJTs. This is high-scoring knowledge.
So our mission today is to move past that sort of anxiety around it and just extract a precise, high-yield framework.
Right.
Something that lets you handle these rare, complex scenarios with total confidence. We want you to know the right compliant action when a situation just goes sideways.
Look, when you're faced with confrontation, it's so easy to react emotionally.
Of course.
We're here to give you that structured thinking process, the one that protects your safety and your professional integrity. It's about staying compliant with good medical practice.
Okay, so let's start with that central tension, the thing that defines this whole topic. Imagine a classic SJT setup. You have a patient who's been persistently aggressive. Maybe it's verbal abuse aimed at a nurse, or they're causing a safety concern in the waiting room.
A familiar and horrible scenario.
Right. You know this is a risk, but your primary duty is care. So what's the core principle? What gives you the green light to even consider stopping care?
It's singular and it's non-negotiable. Ending a professional relationship is only permissible when the breakdown of trust is so severe, so absolute, that it genuinely prevents you from continuing to provide good clinical care.
That is such a vital distinction. So it's objective and clinical, not subjective and emotional.
Exactly.
You're not stopping care because you were offended. You're stopping because the environment has compromised your professional ability to actually do your job.
You've hit the nail on the head. That's the decision. It balances the doctor's safety against the patient's right to continuous care. The GMC covers this explicitly around paragraph 47.
And for the exam?
For the exam, they're testing whether you default to your primary duty, which is care, or if you panic and abandon the patient. The correct answer, the high-scoring one, means you have to navigate that tension professionally.
Okay, so let's unpack that. What are the specific circumstances that GMC cites as valid reasons for taking this really extreme step?
Well, paragraph 3 lists them out. And they are, as you'd expect, very specific and pretty rare.
We're talking about serious actions here.
Very serious. Violence, abuse, or, credible threats against you or a colleague. It also covers criminal behavior.
Like what?
Stealing from the premises, for example, or acting in a sexual way towards staff.
Right.
And then there's the less distinct category.
I think I know the one.
Persistently acting unreasonably.
That last one, that feels like a real gray area. I bet that's a huge exam trap. What does it actually mean in practice?
It means a pattern of conduct that makes delivering care impossible. It's not just a one-off.
So not just one bad day.
No, not at all. We're talking about, say, repeatedly filing vexatious complaints, making constant non-urgent demands that just swallow up all your resources, or blocking access for other patients. It has to be ongoing and properly obstructive.
Okay, now let's flip it, because this is where the exams love to trip you up. What are the crucial don'ts? The things that would immediately fail a compliance test?
The biggest trap by far is the patient complaint. You absolutely must not end a relationship solely because the patient has filed a serious complaint about you.
Right.
If a complaint is made, your duty is clear. Respond to it promptly, fully, and honestly. That's the priority. Terminating care because you were criticized. That scores 0.
What about the resource side of things? A patient whose care is just too complex or takes too much time?
No. You cannot terminate a relationship because the care is too costly or too complex or needs resources you'd rather use elsewhere. That speaks directly to the mandatory non-discrimination rule.
Let's clarify that rule. The GMC guidance is relentless on fair treatment. What does non-discrimination actually mean in this high-stakes context?
It means the decision has to be objective. It just has to be. You can't let your personal views or a patient's protected characteristics,
like their gender, their lifestyle choices.
Exactly. Their religious beliefs, anything like that, affect the decision to end their care. If a patient's smoking contributed to their lung condition, you can't drop them because of that choice. The focus must stay on the threat to the professional relationship, not your personal judgment.
Okay, so we've covered the why and the when. Let's pivot to the high-yield framework. The mandatory stepwise actions you have to take before making that final decision. This is the checklist that's going to score highest on the SJT.
Right, and this pre-termination process is non-negotiable. It's all in paragraph 7. There are 3 mandatory steps.
Okay, step 1.
First, you have to tell the patient that you are considering ending the relationship. And you have to clearly explain the specific behavior that's led to this.
So you're not issuing an eviction notice. You're issuing a warning.
Precisely. Second, you must actively try to restore the professional relationship.
What does that look like?
It means setting clear, written expectations for their future conduct. You have to be able to show you tried to fix things first.
Okay, makes sense. And the third step.
Third, you discuss the situation with a senior colleague, your employer, or the contracting body. You never, ever act in isolation.
I can imagine trying to restore trust after a patient has been, say, verbally abusive is incredibly difficult. Why is that step so mandatory?
Because it demonstrates that you prioritize the patient's welfare and their continuity of care over your own immediate reaction. It also creates a paper trail.
Ah, I see.
If the patient then breaches those new, clear expectations, you have objective proof that you followed the required process before you went to termination.
And before we get to that final decision, what about the immediate safeguarding mandate?
This is absolutely critical. You have to stop everything and get advice from a safeguarding lead if ending their relationship could leave the patient, or anyone close to them, like their kids or a dependent adult, at risk of significant harm.
So that duty supersedes everything else.
In that moment, yes. Your duty to safeguard overrides the process of ending the relationship.
We started with the abusive patient scenario. Is there an exception to this measured, stepwise process in a moment of, immediate danger?
Yes, there is one key exception. It's usually found in primary care regulations.
Okay.
Primary care contracts typically permit the immediate removal of a patient if they've been physically violent or have caused staff to genuinely fear for their safety.
So that's the one time you can act instantly.
It's that rare moment when safety demands immediate action. But, and this is important, even then, all the logistical follow-up duties still remain.
Okay, let's talk about those logistics. The decision is made, the relationship is over, continuity of care is now the paramount concern. What mandatory actions do you take after the decision?
We can use a memory hook here. Let's think of the 3 C's of termination logistics: communication, continuity, and clarity.
I like that. So communication and clarity, tell me about those.
Okay, communication. Inform the patient of the decision and the reasons, in writing where you can. Clarity. Record the decision factually and objectively in the patient's notes. You have to ensure what you write doesn't prejudice their future care from the next clinician. No emotional language.
And continuity. I guess that's the big one.
Continuity is paramount. You must follow local guidance and, crucially, ensure arrangements are made for the patient's continuing care if they can't arrange it themselves.
So you can't just leave them high and dry.
Never. Then, you promptly pass on all the medical records, without delay, to the next provider.
That brings us back to that visual hook you mentioned. Imagine the patient record book is a locked transfer case.
Right.
You can close the relationship, but you're still responsible for safely handing that case off, making sure the record inside is objective and factual, and that the patient has someone new lined up.
Exactly that. And one final point on logistics. You must not end relationships with family or dependents just because you ended it with the initial patient. If children or vulnerable adults rely on you, their continuing care has to be protected.
Right. Let's shift to exam patterns. How does the SJT test this knowledge? I know 2 patterns tend to dominate.
They do. Pattern 1 is what I call the complaint trap. A patient makes a serious complaint. The best action is always, always to respond promptly, fully, and honestly.
And the trap is?
Ranking termination highly because you feel attacked or defensive. Remember, professional integrity beats personal comfort every time.
Okay, and pattern 2, the safety concern. This must test that primary care exception and escalation.
It does. If a patient is violent or threatening, the best action is immediate security escalation and removal if local regulation allows it.
But it's not just that.
No, it's combined with informing seniors or the police, and at the same time making sure onward care arrangements are immediately available. The trap is to ignore the threat, or, on the flip side, to fail to document it all objectively because you're emotional.
So beyond those main patterns, what are the most common trap answers that just fail the compliance test?
Well, they tend to test the mandatory process steps, so anything that involves delaying action or ignoring persistent bad behavior fails to manage risk.
And jumping the gun.
A huge one. Jumping straight to termination without attempting to restore the relationship first, that's a mandatory step missed. Scores very poorly.
What about information sharing?
A big no-no is breaching confidentiality. Discussing it with external non-clinical parties without a clear clinical or safeguarding reason is a major GMC violation. And also, watch out for any answers that suggest refusing treatment solely due to lifestyle or choices. That's the non-discrimination principle again.
Let's finish up with some ultra-short, high-yield, rapid-fire examples. If X happens, you must do Y.
Okay. If a patient consistently misses appointments, the best action is setting clear written expectations for future attendance.
If you, the doctor, are closing your entire practice,
you must give advance notice, usually 3 months, and proactively arrange continuing care for all of your current patients.
And if a patient threatens theft or commits some other petty criminal act on the premises?
Immediate security and senior escalation, that's first, followed by objective documentation, and then you initiate the formal termination procedure, which includes informing the patient in writing.
That was incredibly comprehensive. Let's distill this down into the 3 core principles you need to carry forward.
Takeaway 1. The only legitimate justification for ending a relationship is that the trust breakdown prevents you from providing good clinical care. It's never about inconvenience.
Takeaway 2.
The process is mandatory. You have to attempt restoration, you have to consult colleagues, and you must check for safeguarding risks before that final decision is made.
And finally, takeaway 3.
Continuity of care is non-negotiable. Prompt, factual record transfer and making sure care arrangements are in place are critical compliance points that validate your entire decision.
Remember that the ultimate test, both clinically and in your exam, is whether you can objectively and factually justify your decision to a regulator. It has to be based on safety and the impossibility of providing good care. By following this framework, you not only protect yourself and your staff, but you also fulfill your highest professional duties. Use this knowledge to defend your actions and hopefully sleep a little better at night.